Welcome to another EduMed video, and in the next of this series on the ITU ward round we'll talk about blood gases. Blood gases are a really important part of assessing any patient who's critically unwell, and that's why we use the G in the ABCD approach specifically for blood gases, because it's worth spending a bit of time looking at the blood gases for each individual patient on the ward round. You can divide the blood gas information into really two parts. The first is the respiratory targets and the second is the metabolic targets. When thinking about respiratory targets, what we're really wanting to do is to see whether the patient has adequate oxygenation and adequate CO2 removal. So the question then comes, what is adequate oxygenation? Well, you'll often see people aiming for target PO2s of between 8 and 9, but the reality is that oxygen content in the blood is far more dependent on the amount of hemoglobin that's there and the saturation of that hemoglobin. So generally speaking, what I tend to do is aim for saturations of between 88 and 92% for most patients, and if they've got severe respiratory failure with significant lung involvement, we sometimes even aim for 85%. Now, that's based on the proviso that that's providing appropriate amounts of oxygen for patients and they're not undergoing anaerobic respiration. So if their lactates are starting to rise, if they start to develop liver dysfunction or kidney dysfunction, or they start to show signs of ischemia on their ECG, we would revisit that. But for most people, 85%, even 88% is actually adequate. And if you measure your oxygen saturations when you're on a plane flying at high altitude, you will not uncommonly see patients with saturations of 88 to 85% and not feel anything of it. Carbon dioxide targets are a little bit more variable, and that depends partly upon what patients are used to. And so rather than using a PCO2 value, we sometimes go by a pH. So as long as their metabolic status is stable and they're not acidemic from a metabolic perspective, you can aim for a pH of above 7.25. You will often hear about people talking about permissive hypercapnia. What they're talking about there is, rather than pushing the lungs and trying to ventilate them as hard as possible to get to a normal CO2, you allow the CO2 to creep up a little bit more. Now, as long as you keep the pH above 7.2 to 7.25, the cellular function within the body actually isn't too impaired. And so actually aiming for a pH with the CO2 is probably a more sensible way of managing patients when they're acutely unwell. When they become less unwell, then aiming for PCO2s of between 4.5 and 6 are probably adequate for most patients. The slight proviso to both the oxygen and the CO2 targets is neuroprotection, and that's a talk in and of itself where we use totally different targets, and that's based on the cerebral autoregulation and trying to maintain intracranial pressures at a normal level. But we'll talk about that later. In terms of metabolic status, it's very similar to what you would do on the ward, so you'd want to aim for a normal base excess of -2 to +2. And a normal bicarb, usually above 20-22. In terms of managing a bicarb, you will often see patients on frusemide, and frusemide causes quite significant metabolic alkalosis. So if you see the significant alkalosis starting to develop, think about your frusemide dose and think about what you're doing. Also, patients with chronic hypercapnia, if they've got COPD or they've got severe respiratory failure and you've been running them at slightly higher CO2s, you will often find that the kidneys try to compensate for that by increasing the amount of bicarbonate and other basic proteins, and therefore you can start to see an increase in your base excess. You can somewhat correct that by reducing both your bicarbonate and your base excess using drugs such as acetazolamide, and so we sometimes consider using this in patients who have been chronically ventilated with very difficult to ventilate lungs. They've been running high CO2s for a while, but now the lungs are getting better. And if you keep the bicarbonate in the body, the patients will hypoventilate to try and maintain a normal pH. So by getting rid of the bicarbonate, using things like acetazolamide, you can then decrease the pH and allow the patient to breathe up that little bit more. Most patients use pH as their driver for CO2 respiration, i.e. their minute ventilation. So if you've got a patient with a high pH, then they're going to hypoventilate so as to not allow the pH to become too great. In terms of the bicarbonate, rarely we do use intravenous bicarb to top up their bicarbonate levels. That's really got to be done under the direct vision of a senior doctor, because you have to ask yourself the question, why are they acidemic? If it's just a matter of the patient being hypovolemic, or they've got, say for example, a bicarbonate losing enteropathy or nephropathy, then yes, intravenous bicarbonate is a great drug. If, however, it's because the patient has got significant bowel ischemia, for example, you can make the metabolic status better by giving bicarbonate, but you're not treating the underlying condition and allowing it to get worse. So always think about what the cause for the acidosis is before you give something like bicarbonate, if you choose to give it at all, and a lot of people don't. So, in summary, blood gases are really important. You can divide them into the metabolic component and the respiratory component. If patients are really unwell, you can do blood gases every 15 minutes up until every hour. And for the most part, in the first few hours of an ITU admission, whilst you're trying to get their metabolic status optimized and whilst you're trying to optimize their ventilation, doing blood gases every hour is not unreasonable. Once patients become more stable, every 4 to 6 hours is entirely reasonable. And then once they're much better than that, you don't actually have to do blood gases at all. And if you do them, less frequently is absolutely fine. So once a day.